Good afternoon. I'm Justin Manaloto from the Medical Affairs of Zuellig Pharma. As part of our vision of being a catalyst for the achievement of better health outcomes of all Filipinos, we are very proud to bring you one of the most exciting and wonderful new medication that we can utilize in our fight against diabetes, which is dulaglutide. So to guide us this afternoon into knowing more about this new medication, we'll be with the two of the most sought after experts in the field. Dr. Roberto Mirasol, who is the past president of the Philippine Society of Endocrinology, Diabetes and Metabolism, Philippine Association for the Study of Overweight and Obesity, Philippine Lipid and Atherosclerosis Society, and the ASEAN Federation of Endocrine Society. He will be joined by Dr. Sjoberg, who is the head of the UST Hospital Diabetes Center, chair of the Department of Medicine of the same institution, and also the past president of the Philippine Society of Endocrinology, Diabetes, and Metabolism.
Good afternoon, everyone. Welcome to this afternoon session. We're going to talk about how to spark the patient's motivation for change with an effective once-weekly GLP-1 receptor agonist therapy. I'm Sjoberg. These are my disclosures. And for this afternoon, we'll talk about the patient who needs motivation to keep going. His sugar has been hovering around 8 to 10% over the past several months. He hasn't had a cardiovascular event, but has risk factors beyond diabetes alone. He's on the heavy side. Oftentimes, he feels guilty at his inability to get his glucose under control. And he's now discouraged at his lack of progress and is losing motivation. So let's see how we can help this patient. We know that diabetes is a progressive disease. Early on, even before they develop diabetes, there's going to be insulin resistance. However, hyperglycemia does not happen because this will be matched by increased insulin secretion. But over time, there's going to be beta cell exhaustion. As the beta cells start to fail, the patients will have progressively increase in blood glucose, beginning with impaired fasting glucose and impaired glucose tolerance, what we call prediabetes. As the beta cells fail further, then the diabetes will come out and the patient will get diagnosed with type 2 diabetes. It's oftentimes said that at the time of diagnosis of type 2 diabetes, patients probably have lost about 50 to 80% of their beta cells. And generally, when we talk about chronic complications of diabetes, we group them into two: the microvascular complications, including neuropathy, retinopathy, and nephropathy. And for macrovascular complications, we talk about coronary heart disease and stroke. But add to this, we also include, and to this group, we include peripheral arterial disease, and oftentimes the most recently talked about heart failure in patients with type 2 diabetes. So let's go back to this patient. Oftentimes, even before they get diagnosed with diabetes, their cardiovascular risk is oftentimes driven by their underlying risk factors, their comorbidities, like hypertension, central obesity, and dyslipidemia. And once they get diagnosed with diabetes, there's going to be additional risk of hyperglycemia. It's often said that after 8 to 10 years of diabetes, many of our patients will develop coronary heart disease or coronary heart disease equivalents. And just to show how badly we are doing in terms of reaching glycemic control, in the Panorama trial, they've shown that about 40% of patients with type 2 diabetes in the EU on oral therapy alone failed to reach an A1C of less than 7%. There are data also showing that a lot of our patients hovers around 8% or higher for about 6 years before new treatment will be added. For oral anti-hyperglycemic medication, oftentimes it takes about 1.6 years before a drug will be added. Much worse, it takes about 6.9 years before insulin will be added in many of our patients despite poor glycemic control. So which brings us to an effective drug. Let's talk about how does incretin effect impact our patients with type 2 diabetes. So we know very well, among healthy subjects, for many years, we know that as one eats, before the glucose goes up, the pancreas will know, and this is what we call the incretin effect. This is an experiment that they did following the glucose and insulin level of patients when they were given oral glucose. And on another day, using IV infusion, they titrated the glucose, IV glucose, to mimic the timeline or the glucose level when they were given oral glucose. And again, they measured their insulin secretion. This time, when given IV, the insulin level is much lower. So this difference between insulin level when glucose is administered IV versus orally is what we call the incretin effect. And has been found to be effective in patients with type 2 diabetes. So again, to review, as one eats, the pancreas would know, and is driven by active GLP-1 and also GIP. These are the two incretins that promotes insulin secretion by the beta cells and at the same time promotes glucagon suppression by the alpha cells. These drugs also leads to slow gastric emptying, leading to lower postprandial rise in glucose, and also it promotes satiety. Just to review the multifactorial pathogenesis of type 2 diabetes, we often talk about the octet. And the pathophysiology oftentimes contribute individually to hyperglycemia. With incretin-based therapy, GLP-1 receptor agonists particularly, it addresses multiple pathophysiology of type 2 diabetes. It goes from improving incretin effect and improving insulin secretion, suppressing glucagon production by the alpha cells, both of which contribute to improving absorption of glucose by the muscles and suppressing hepatic glucose output. It also promotes satiety, and these are the targets of incretin-based therapy in promoting better glycemic control for our patients. So going back to the patient, so what can we offer him? Present guideline says after metformin, if the A1C target is not reached, it used to be just choose a medication based on their individual characteristics as long as you do not promote hypoglycemia and there's minimal weight gain, then you are doing a good job. Over the past 2 years, the guidelines has changed. It says that after metformin, if the patient did not reach their target A1C, the next question to ask is whether your patient may have underlying or are they at high risk for atherosclerotic cardiovascular disease, heart failure, or CKD. If they have a predominant atherosclerotic cardiovascular disease as their comorbidity, the drug of choice after metformin should be GLP-1 receptor agonist. And if the problem is predominantly heart failure or CKD, then SGLT2 inhibitor would be the next drug of choice after metformin. In an event that the patient cannot tolerate SGLT2 in patient with heart failure, then the next line drug after metformin should be a GLP-1 receptor agonist. About 30% of our patients with type 2 diabetes will belong to this high risk or established group. 70% will not have these established complications, therefore, that we worry about risk for hypoglycemia, the risk for weight gain. And then one can see that across the board, GLP-1 receptor agonists repeatedly appear to be the next line or at least one of the next line drug after metformin. And these guidelines have shown that basal insulin, what used to be the first injectable or the recommended first injectable, is now lower on the list of priorities in terms of adding medications to metformin. If one goes to the right side, it says that if injectable therapy is needed because of inability to reach their target A1C, GLP-1 receptor agonist should be the first choice. And if A1C is still above target, that's the time that you add basal insulin. And if that still fails, we should add prandial insulin all the way down to basal bolus, meaning 1 shot of basal insulin plus 3 shots of prandial insulin. So let's review some of the proven and sustained efficacy of incretin-based therapy, particularly dulaglutide that led to its approval as used for patients with type 2 diabetes. So what are the indications for dulaglutide? Dulaglutide is indicated in adult patients with type 2 diabetes to improve their glycemic control. It is approved as monotherapy when diet and exercise alone do not provide adequate control, or patients whom the use of metformin is considered inappropriate due to intolerance or contraindication. It's also approved for add-on to any form of therapy and any injectable except DPP-4 inhibitors. So it can be used on top of metformin, sulfonylureas, TZDs, SGLT2 inhibitors, alpha glucosidase inhibitors, basal and prandial insulin, but not DPP-4. The reason for that is because uh, GLP-1 receptor agonists are generally pharmacologic level of incretin effect. It also maximizes the incretin effect. So DPP-4 inhibitors will be just kind of a waste of money for your patients because you have maximized the incretin effect of the GLP-1 receptor agonist. The recommended dose for most of our patients is 1.5 milligrams once weekly. It's 0.75 as monotherapy and 0.75 milligrams also for patients above 75 years old. So these are the different clinical trials that led to the approval of dulaglutide as monotherapy in combination with insulin and different forms of oral anti-diabetic agent. So as monotherapy in award 3, we'll review this. As the 2-drug combination with another drug, as 3-drug combination, and also more complex including the use of dulaglutide in patients on insulin basal plus prandial. Across the board in the award 6, for example, on the left side versus another GLP-1 receptor agonist that's injected on a daily basis, liraglutide, they are equally good in terms of A1C lowering. In award 2, we're going to review this in a bit, that in fact, in award 2, dulaglutide fared better than a daily basal glargine. And compared to other GLP-1 receptor agonists, in this case exenatide, it did better in terms of A1C lowering. It also did better with another incretin-based therapy when compared to sitagliptin in terms of A1C lowering. So let's review award 2. This is a study that randomized patients who are on metformin plus glimepiride, whose A1C is not well controlled yet. They were randomized to dulaglutide versus a daily insulin glargine. And in the interest of time, let's just review the result. Dulaglutide led to almost 2 times better glycemic control in terms of A1C target versus basal insulin. There was about a 0.5% percentage better in favor of dulaglutide. And if one looks at the number of injections throughout the 1-year trial, for dulaglutide, it was only 52 injections. For glargine, it was 364 injections throughout the 1-year trial. Next, let's look at award 6, comparing dulaglutide versus liraglutide. I've shown you earlier that they're equally good in terms of A1C lowering, up to 1.4% for both of them. But they did a sub-analysis in this patient, categorizing patients with A1C, baseline A1C of less than 8.5% or more than 8.5%. Just like most of the most of the anti-hyperglycemic trials out there, if the baseline A1C is higher, generally you get a bigger A1C lowering with dulaglutide at about mean average of about 2.1% lowering if their baseline A1C is greater than 8.5%, and about 1.2% if their baseline A1C was less than 8.5%. In award 5, comparing dulaglutide with sitagliptin, I've shown you earlier that dulaglutide did better in terms of A1C lowering, but what I'm going to show you as part of this award 5 trial is the durability of the glucose lowering effect of dulaglutide over 2 years. So again, with dulaglutide, there was a sustainable and durable lowering of A1C below less than 7% even after 2 years of this trial. To continue with the journey of our patient to overcome the barrier of achieving good glycemic control, it is my pleasure to share the virtual stage with one of my esteemed colleagues, Dr. Robert Mirasol.
Good afternoon, everyone. Thank you for joining us this afternoon in this wonderful discussion on dulaglutide. Thank you, Sjoberg, for sharing with us wonderful data about dulaglutide. My task this afternoon is to discuss to you how this drug has overcome the barriers of actually being able to use it in the long run for our patients. These are my disclosures, and I'll discuss how to overcome the barriers of our patients who are on these kinds of drugs. Could dulaglutide experience give patients the motivation they need to start and stay on your treatment? This slide tells us that, in fact, when you are using dulaglutide, the advantages of this new drug will lead us to be on the will lead us to stay on this new treatment for the longest period of time. It's once weekly. There is a pre-attached hidden needle, so those which have needle phobia would be greatly uh, motivated to use this because they don't see the needles. It has a preset dose. You don't need to calibrate, and you don't need to preset your pens. It starts working after the first dose. So after usage of the first dose, then this drug will already be starting to work. And it can be taken anytime of the day with or without food. So the timing is very important because most of our patients are busy. And if there is an advantage that you could take this drug at any time of the day, then this would really be helpful. But more importantly, clinically, there is low incidence of hypoglycemia, which was noted with the use of this drug, and low potential for weight gain. Now, in this study, which is comparing dulaglutide with exenatide, patients on dulaglutide were less likely to discontinue compared to patients on exenatide once weekly as well, within 6 months of titration. These are two drugs of the same, uh, as we say, they're all GLP-1 analogs, also every week, similar to that of dulaglutide, but there was less likely discontinuation, what was noted with those patients who are on dulaglutide. These are days to discontinuation, and as we see here, it actually plateaus dulaglutide usage versus that of your exenatide. Now, in terms of once a day usage, liraglutide, this is once a day liraglutide, and this is once weekly dulaglutide. Again, with dulaglutide, patients or on dulaglutide, they were less likely to discontinue compared to liraglutide within the 6 months of treatment initiation. Now, the simple administration gives the patients a different kind of experience, and that 99% of them reported that the dulaglutide pen was easy or very easy to use. 98% found the dulaglutide pen convenient to self-inject, and 97% was willing to continue using the dulaglutide pen. Now, it's as easy as one, two, three. All of you, I'm sure, have seen a dulaglutide pen. So it has a gray cap wherein it caps the, the needle, and it has a, a locking or unlocking mechanism here. And finally, you have your uh, 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 what we call the press and hold button, wherein you will administer the drug. So first you remove or uncap the pen, remove this and throw it away, and then shift from the unlock position to the from the unlock position. I'm sorry, from the from the lock position to the unlock position, and finally press and hold, and keep it there for about 5 seconds until you hear the second click of your pen. In which case, it was already administered. Now, in terms of side effects, you will see nausea as one of the major or most common side effect that we see with this drug. And nausea is usually transient in nature and usually subsides within the first two doses of the medication usage. Now, equally important as starting the medication would be staying on the drug. And this study looked at different kinds of drugs, metformin. Here we have oral, branded orals, other GLP-1 receptor agonists uh, apart from dulaglutide, your basal insulin, and dulaglutide. Those which have filled the second prescription was higher with those of dulaglutide. Now, if you extend it to fourth prescription fill, dulaglutide will still be 65% versus that of about 43 to 50% with the other drugs, especially insulin, which is about 43% of the fourth prescription pill. So meaning they start these patients start on dulaglutide and will be on it for the longest period of time. Now, it's also shown to demonstrate powerful adherence in real world data. These are patients which are adherent to the drug. This is insulin glargine, and this is actually dulaglutide, 57.1. And they're more likely to be adherent at the end. These are PDCs in percentage. And you would see that dulaglutide was more likely to be adherent than basal insulin users. So 57% versus that of 29% for those who are on insulin users. Now, this was done on a huge clinical trial, although it was retrospective. It was a 1 year clinical with economic outcomes from an observational retrospective study. Patients greater than 18 years with type 2 diabetes, newly initiating on dulaglutide versus that of insulin. They included in the study 4,296 patients, which met the inclusion and exclusion criteria, and they were matched with propensity score matching of dulaglutide versus that of basal insulin. And the cost assessment population consisted of 522 pairs. They were assigned to one of the two cohorts based on the earliest field data, the index date, for one medication with dulaglutide versus that of patients on basal insulin. And they looked at the change in hemoglobin A1C from baseline to 1 year follow-up, and hemoglobin A1C levels at baseline, 3, 6, 9, and 12 months were also looked at, and the proportion of patients achieving hemoglobin A1C of less than 7, less than 8, and a reduction of greater than 1% at 1 year follow-up were looked at. And the patients were, the secondary outcome in terms of adherence were looked at. And if they were adherent with 80%, they were classified as adherent. Limitations in this study, they were not randomized because these were retrospective, and they just used propensity matching, score matching for this. And the differences in the observed patient characteristics between the unmatched cohorts could imply that generalization of your clinical and economic outcomes of the full populations may not be the same as that. And patients were included based on enrollment in their health insurance plans, and that also the pharmacy claims indicate that the prescription was filled not if a medication was used. So it means that they got the medication, but it does not necessarily mean that they used the medication. And patients were assigned to treatment groups based on their index prescription, and the analysis did not account for changes in the treatment during the follow-up period. So meaning on first instance where they used the drug, they were assigned to that group already. But if there were changes in the middle of the observation period, this was not recorded anymore. So those are the limitations of the study. But indeed, it is a useful study, and they were able to come out with generalizable data with this study. So it was able to show that, in fact, there was significant reduction in hemoglobin A1C. And the simple approach to a first injection was the claim of those using dulaglutide. And 99% of the patients found it easy because there's no reconstitution or priming required. There's no need to see the handle or the pre-attached needle. And each pen contains a single dose of dulaglutide. So one single dose with each pen. And it's simple, and it's simply delivered because it's automatic dose delivery. So you don't have to calibrate or to put in a dose in your patients. You just have to uncap, place to and unlock the position, and then press and hold onto your pen and count five. And once you hear the second click, then you've delivered the dose, and it has a sustainable effect. Now, in terms of safety with the use of drugs, of course, we all know that it is safety, but the adverse reaction was with this drug is actually mostly centered around the GI. So usually, nausea would be very common, diarrhea as well. Patients would have some form of vomiting and abdominal pain. But as I mentioned earlier, after the second dose of dulaglutide, usually the symptoms are usually lessened and they're more tolerable. Now, in terms of decreased appetite, this was common, and some of our patients like this because this will lead to loss of weight. Dyspepsia is also common. Constipation, flatulence, abdominal distension, and gastroesophageal reflux disease and eructation or sour eructation could also be seen. Now, those which are not GI related, fatigue is rather common in some patients, and very uncommonly, they will see pain or uh, in the injection site reaction. So, in general, it will be GI side effects. As we said, very commonly we see this, but after 2 weeks, they usually this adverse reaction usually abates. Now let's look at a case study, Max, a patient with type 2 diabetes with CV risk factors. So Max is 66 years old. He's a medical physicist. He was diagnosed to have diabetes 9 years ago. He has a father who developed MI at age 40, so premature coronary artery disease, non-smoker and compliant with medications, knowledgeable about diabetes management. He's concerned about hypoglycemia in his weight. He also has hypertension and some form of dyslipidemia, especially an increase of your total cholesterol. You do your glycosylated hemoglobin was 8.5%, and the patient's GFR is rather low now at 29. The weight is 63, and the BMI is about 23 kilogram per meter square. Blood pressure is within acceptable limits. Medications for anti-hyperglycemic, your patients are using a DPP-4, sitagliptin, 50 milligram once daily. And for lipids, patients being given atorvastatin 20 milligrams, and for high blood pressure, losartan of 50 milligrams once daily. So after discussing his case, because his hemoglobin A1C is still high, and you discuss the case, you want these patients to be in better control. And you tell him that perhaps a drug which can bring down his blood sugars, which is effective in bringing down the blood sugar, and at the same time also help him lose weight would be a GLP-1 receptor agonist. And you decide on dulaglutide, which is 1.5 milligram once weekly, which was started on this patient. You continue the statin of this patient, the atorvastatin. You added aspirin, and the hypertension treatment was intensified for this patient. The test dosing and patient training was performed on him via online call, and 3-month follow-up visit was scheduled for this patient. On follow-up, you notice that the hemoglobin A1C was down to 7.4, and all the CBGs were normal, and the weight was down, although not significant, but the weight was down or not increasing, in fact, 59.5 kilograms, and the blood pressure was within normal. There was no side effects that was noted. There was no hypoglycemia, no nausea was noted in this patient. So conclusions for this patient is that was easy to initiate. There was no hassles of daily injections. It's very cost effective, and device makes it very appealing because the pen is robust and does not jump. And it's an auto injector, no need to carry needles or additional cost of needles, and less needle phobia for our patients. So dulaglutide with shown significant hemoglobin A1C reduction. It's once weekly dosing, and it's ready to use as a pen. So I think that was my last slide. And for your questions, please ask your Zuellig Lilly representatives, and they will be more than willing to answer your questions. Thank you very much.